Bill Gradishar, professor of medicine at Northwestern University, where I am also chief of hematology oncology. The duration of anti-hormone therapy in patients with early stage disease has been addressed for the last 25 years. We initially started out with the dogma that 5 years of tamoxifen, when that was the only drug available, was optimal. And then with the introduction of aromatase inhibitors for postmenopausal women, we started to get into the exercise of trying to determine first if an aromatase inhibitor is better than tamoxifen, if sequencing an aromatase inhibitor with tamoxifen would offer some advantage over tamoxifen alone. And then finally, we started looking at longer durations of therapy, be it 5 years of tamoxifen followed by an aromatase inhibitor, or 10 years of tamoxifen, or some permutation of all of the above. So I think what the conclusions from all of those trials, which were conducted over 20 years, are the following. One is that certainly endocrine therapy is better than not getting endocrine therapy, and 5 years of therapy is better than shorter durations. If you're giving tamoxifen, it appears based on the ATOM and ATLAS trial that durations of 10 years versus 5 of tamoxifen does translate into better outcome for patients. And keep in mind, we have the observation that has been made from thousands of patients that regardless of their stage or the volume of disease, as you follow patients out from 5 to 10 to 15 or 20 years, and those who got 5 years of tamoxifen, even with the most favorable group, there continue to be recurrences out even at 20 years. Not a lot, but there are patients. And as the stage goes up, the fraction of patients who will have a recurrence also increases. So this begged the question of whether 5 years was sufficient. And now for most patients, we would certainly, if they're postmenopausal, start out with the idea that they get 5 years of an AI, an aromatase inhibitor, and durations beyond that have been evaluated. And most of those trials, certainly 10 versus 5, have failed to demonstrate convincingly that you really impact on distant metastatic disease. There are a couple of trials that suggest that maybe 7.5 years is better than 5. But with an aromatase inhibitor, it's a little bit murky when you get beyond 5 years. And we do have tools now that we can use, just as we talked about the recurrence score or the mammoprint test as giving us information about who may need chemo or who can avoid it. We have a variety of other tests as well, such as the breast cancer index as one example, that seeks to help illuminate or define that patient who should get or can avoid longer durations of therapy beyond 5 years. So 5 years remains the minimum. And AI is better than TAM, certainly in a postmenopausal patient population. There are select patients, of course, where in addition to any of these things, we may have to add ovarian suppression, particularly for very young patients. But beyond 5 years, unless you're talking about tamoxifen, which is better at 10 years than 5, an aromatase inhibitor beyond 5 to 7.5 years is less clear that there is an advantage. And I think that sometimes these molecular tools that we've referred to may help define the patient who can avoid or should continue beyond 5 years of an aromatase inhibitor.